Okay. And now, Gergerly or Gulchin, do you mind if I make you co-host so that you can accept participants if I don't see them?
Of course, no problem.
Thank you. Okay, Gulchin, so I make you. Thank you. Okay. Hello, everyone. Welcome. Thank you so much for being here today. I see some familiar faces and names. So, my name is Nora Lázaro. I am Patient Engagement Manager at Eurordis. Before we dive into today's topic, let me just share some quite quick housekeeping notes with you. First of all, this webinar is being recorded and then it will be available in our YouTube channel and in our Patient Partnership Hub. Then, if you can please keep your microphones muted while the speakers are speaking, that would be very welcome. And also, please feel free to use the chat at any point during the webinar, or you may raise your hand function during the Q&A session that will be towards the end of the session. So today's webinar focuses on the work of ERN LUNGs and Diagnosed Patients Working Group, and in particular on the development of an undiagnosed patient pathway for people with rare respiratory symptoms who remain without a diagnosis. What makes this work especially important and the reason why we are highlighting this work here today is not only the methodology that they have used, that you will see it's very interesting, but also how it was developed through close and structured collaboration between clinicians and patient representatives in the project. This project was recently recognized as a winner of the Eurordis Patient Partnership Good Practice Challenge in 2025, which also speaks to the strength of the patient partnership approach embedded in the work they have done. I am very pleased to be joined today by our two speakers. We have Dr. Anna Kerpel Fronius, radiologist at OKPI and clinician in ERN LUNG, who will bring more the technical clinical perspective on undiagnosed respiratory diseases and the methodology they've used. And then we have Gergerly, Mesaros project manager and IPAC lead at ERN LUNG, who played a key role ensuring meaningful patient involvement through the whole process. Together, they will walk us through both the methodology used and also the patient partnership approach they have followed along all the process. So with that, I am very happy to hand over to Anna. Anna, please, the floor is yours.
So, Nora, thank you very much. And thank you very much for having me, because I think it's quite rare for a radiologist to speak on such a patient-centered idea. What we've been trying to do for the past, at least 18 months, that we're trying to figure out what is the best way to guide a patient through with a pulmonary disease that for some reason is staying undiagnosed. Can we have the next slide, please? I am, just a short introduction. I'm a radiologist at the National Korányi Institute of Pulmonology, and this is the biggest pulmonology hospital in Hungary. And we have one of the oldest ILD teams here. We have the biggest adult cystic fibrosis population. So we see a lot of diseases that are not as common as they would be in a day-to-day practice. This is how I got involved with the ERN LUNG project, and this is how they, when my institute, the Korányi, has joined the ERN partnership. I was asked to join this project. So I am going to talk about my own perspective as a radiologist, and just to show you what it means. Can we have the next slide, please? Okay, so this is just an example. So I'm not going to talk about interstitial lung diseases, but interstitial lung diseases is a big umbrella term for over 200 different types of disease, and each of them in itself are rare diseases. This is a very typical. So if a patient comes in and I see that CT, I will be able as a radiologist to tell that this is lymphangioliomyomatosis, which is a very difficult word to pronounce, but this is a established ILD within the 200 different times. So sometimes all it takes is a good CT for the patient to get the diagnosis. May we have the next slide, please? So, but the classification, so the first classification we worked with for a long time came from 2002, and we have a few different named interstitial lung diseases, and there in green we see unclassifiable interstitial lung disease. Next. Then we went to 2013. It was now slightly differently packaged. So we have slightly different entities. We already have rare interstitial diseases here within this grouping, and we still have unclassified interstitial diseases. And then maybe we have the next slide. Last year, oh, sorry, it's already 2 years ago, but so in 2024, it has been completely reclassified, and now you can see that there are a lot of different entities there, but at the end, we still have unclassifiable interstitial lung disease. Next slide, please. And this is very important for us, for a clinician, because then we know that we still have work to do, but this is very frustrating for the patient. And on the other hand, I think this is important to mention, it's actually quite frustrating for the doctors as well, because we as doctors we love the scenario where the patient comes in, we get the patient history, we do a few tests, tell them, this is wrong with you, this is how I'm going to cure you, give out a few medicines or do a surgery, whatever, and then the patient is healthy. So this is what we like to do. But there are cases where, despite our best efforts, so for the doctor, this is frustrating because we are thinking of everything that could be done, and still we do not know what's wrong with the patient. That's why we need a patient pathway, and that's why we need multidisciplinary discussions, and we need this sometimes with patient representatives. So I don't think that a patient representative has to be there for all multidisciplinary discussion, but when we are figuring out how to manage a very complex case, I think it's good to have someone who has a vision of what the patient is going through. Please, may I have the next one? So this is Lisa Geets has been someone who worked very hard in this project, and this is one of her slides. What we were thinking of is we have the undiagnosed or sometimes, unfortunately, misdiagnosed patient pathway. So once we have this undiagnosed patients, there are a few things that we should reconsider before going a level higher. So do genetic diagnostic, do hemodynamics, go back and take the history. Sometimes it's patients do not think to tell something that might be important for us, but might not be important for them. For example, what sort of pillows do you use? Because it could be that they are actually feather pillows, and that's where your problem is coming from. And of course, imaging, lab results, pathology, pulmonary function testing is all a part of the package that we have to redo. And then, of course, it's quite important to go through a checklist of a few diseases that are diagnosable but not very common. So cystic fibrosis, different interstitial lung diseases, primary ciliary dyskinesia, and pulmonary hypertension can all be something that is not as easy to diagnose. So patients probably have to go to a specialist center, and then maybe it can be figured out that this is what's wrong with them. And if everything comes back and we still don't know what's wrong, this is when the patient should go into the ERN LUNG pathway, where and we are setting up for this an expert panel, and a clinical workup will follow, so we will be able to diagnose the patient. Next. So this is how we did the work, and I'm going to show you a few things like that. This is the Miro board, and it was actually very fun to use, because what happens here is we put on a lot of different things. So everybody, when we have an idea, we can write into here, we can put on post-it notes. And so we had a panel of pulmonologists, pediatric pulmonologists, pathologists, pulmonary lung function specialists, bronchologists, radiologists, so imaging was there, and laboratory specialists. And we are all trying to figure out what is important and what's not. May I have the next one? Just click one.
Sorry. Yeah.
So this is just a part of the Miro board. So these were the things that we were thinking has to be addressed. For example, red flag symptoms, lifestyle, and next, please. And I think this is one of the most important things for us today. Increasing the visibility of suspected rare lung patients within the healthcare system through coding of undiagnosed conditions and the use of a registry system for undiagnosed patients to enable timely referral to specialists for multidisciplinary team panels. I think this is a very important point because these patients are probably suffering on their own. So they are here and there within the healthcare system, stuck somewhere in the system. So what the pathway should do is try to find these patients and try to find these doctors so that the patient can smoothly transition into the ERN lung. Next one. Okay, so this is the next one. I'm just showing the complexity. So these were a few of the red flags. We will have a nicer slides of the red flags, but things like repeated number of visits, more than 2-3 infections, prolonged infections, and what the question is, do we tested this patient enough? So are there any other tests that we should do that might lead to a diagnosis? And the other thing is, can a red flag be ruled out because it was not the correct treatment that the patient received? Next one. So this is a very so these are how we are supposed to identify the red flags. First of all, repeated visits. So the patient comes back with the same problem and nothing seems to help. Then we have patients who come back with infections. The infections are too long or they repeat themselves. And despite the best treatment or the thought best treatment, the patient is not getting better. And the next one is atypical symptoms, when we see something that should not occur in that age group or in that gender or in that or with that infection, whatever. So something that is not typical for the picture. And these are red flags when we should start to think about, is this patient on the right track or should I relocate them to the ERN lung pathway? Next one, please. Okay, next. So these are my very complicated board. So, and because now I'm talking to the mostly to patient panels, I did go on for patient needs. So the patient needs peer support. They need This is very frustrating to live with. I have to emphasize that. So they need psychosocial support because they have their symptoms and nobody seems to be able to help them. Next one. Yes. So, and this is what patient organizations can do. They can provide trusted information and improve patient health literacy. And they can help, and I think this is very important, to help them navigate within the healthcare system and to know their rights. What rights do they have within the system? Next. Okay, and this is what I've already talked at the beginning. So this is what is needed. A checklist before entering ERN lung. So only those patients who really have an undiagnosed patient are referred to ERN lung, but preferably everyone who fulfills this checklist should be referred there. Next one. I think I am. Yes. And next. So, and this is what we have discussed at our last meeting at the Miro board. So to provide psychosocial support, of course, it has to be discussed who can provide this. And how do we know? Because there are patients who are asking for support, but there are those who will not because they don't even know that they can have this support. And patient organizations can help us, can help the patient to manage their illness before going through everything to go to the undiagnosed patient pathway. They can probably help with giving ideas, what you should do, what you should ask, how to prepare to go to your doctor, what are the extra things that might be necessary. And then, of course, they will be able to help them through the special ERN undiagnosed patient. Once they arrive at the end and they are there, the multidisciplinary team, they will be able to support them there as well. So I think this is how the whole thing comes together. So once again, what we are trying to do as doctors is to give the best possible care to the patient, but sometimes we are stuck, and this is when we need extra help, and this is when patients should be referred further to specialist centers where they will think about diseases that are, as of today, not diagnosable. And with that, I thank you so much, and I'm going to give the word to Gergely, if I'm correct. Yes.
Thank you, Anna. Yes, now I think Gergerly will focus more on how the collaboration was established and how you worked together and what was successful, some tips you will see. Gergerly, the floor is yours.
Yeah, many thanks, Nora. Also, many thanks for a very well welcome. And actually, it's a great honor. And also, I'm very glad to be here for the second time. Probably you must recall that 2 years ago, ERN LUNG was also a winner with the Go East project. Now we are rocking with the undiagnosed patient pathway. Nora, is it possible that you go back one slide, please? Because I think it's very important to probably some of the slide is missing. I would like to see the Eurordis map on the patient partnership framework where we see all the areas of collaboration and
Yes.
guiding principles as well as the enablers. So that would give a very nice frame of my talk. But until you find, let me just deep dive in this very nice slide. It's a little bit busy.
There you go.
Yeah,
Magic.
that one. Thank you. Sorry for the technical problem. I thought that it is included in the master slides. So I really hope that many of you already aware or familiar with this slide. I think it's a very nice approach how patients should be included and involved in each and all work ERNs are doing. It's a very structured, however, very visible slide where you can see some of the guiding principles which might be helpful once you are thinking about whether your collaboration with your physician partners is really a partnership or it's rather you are a mandatory tick box that, okay, patients were consulted. Also, it also helps you to better understand what kind of areas you can collaborate with your physician partners. And naturally, if you see such opportunity to work with physicians, even as part of a multidisciplinary team, there might be some enablers you need to always keep in your mind because that might help you to really work and make the best of your collaboration. Next slide, please. Yes, as I mentioned, it's quite busy and probably you might not be able to read all the text, but later on you might revisit the video or I do not know whether we are going to share the slides, but
Yes,
you can
we can share.
Also check this one. I just mark some of the main points which were really important within the undiagnosed patient working group. So one of them was continuous involvement. As I mentioned, sometimes it happens that at the very last phase when patients and patient representatives are invited to such work. But I'm very grateful to Matt Johnson, probably you might know him, who was strong enough and together with me we managed to discuss with our coordinator that we would like to have a different approach. So as a result of this discussion, it turned out that it's also possible to make simultaneously working groups. So this has not happened like, as I mentioned previously, that patients were only involved to have a mandatory approval at the end, but simultaneously parallel panel discussions happened. So we as patients and patient representatives, together sometimes with some physicians, and also with the help of the how we call network coordination team within ERN LUNG, so those who are providing administrative help. So with their help, we managed to organize some of these workshops, which were already highlighted by Anna. But there was also bridges between the two work streams. So you should not envisage or imagine this, that at the very end we only just met, but we have some nice discussions and we have merged sometimes our discussion. But the continuous involvement happened in this way. So not only participating in the physician pathway or the physician workstream, but we also managed to launch an own patient focused one, which was, I think, very, very effective. So we managed to deliver the red flags you might already have seen. And we managed to supplement some of the points which were actually not touched upon by the physicians. The other one is complementary, and I will come back to this later, but it also coming from the structure, as I mentioned. So there are many, many things physicians are better than us, but probably in some cases we might be better and we might be the experts of our feelings, of our condition in terms of how we are reacting for some of the medications and so on. And as Anna mentioned, it's also important to emphasize patients are facing when they are in a mis or an undiagnosed status. This undiagnosed patient pathway actually is quite unique. However, it is part of the Jardin project. Jardin is a global European project which is aiming to embed or integrate ERNs within the local healthcare system. And the third one, which I try to emphasize on this slide, is the teamwork. So I do not know how busy or how active your ERN in terms of patient partnership and collaboration, but we are very lucky within ERN LUNG that many, many volunteers we managed to onboard. So sometimes there are some projects or there are some tasks. It's very difficult to find someone who is participating or actually contributing to this, because sometimes, okay, I might have my name on the list, but you actually need some work to deliver. But it was a very special project. It was very interesting also for patients, as it has been already mentioned by Anna, and we already know this, that many patients are facing this misdiagnosed or undiagnosed status. However, from a physician point of view, there's a very special definition of when patients are considered undiagnosed. In the previous slide, you can see this receiving a special ORFA code, and it means that as per the current state of art, there's no possibility to identify the patients. Naturally, there might be some advances on this, and as we know, some publications, at least 80 new rare diseases are identified per month. So the number is growing, and we really hope that the gap will be closing. So we have even higher rare diseases, but we hope that we manage to diagnose more and more in the coming years. But as I mentioned, teamwork was very important in this part, and it was really great to see that many patients revisited these workshops and really contributed even between the webinars when we received some homeworks. Next slide, please. Again, a very nice slide, and let me just refer back to the original slide, where there was a map how the patient partnership itself should be assessed from this perspective. On this slide, you might see some more details or pieces of information about the areas of collaboration. It can be different, like sharing, consulting, co-creating, or involvement. So when we are talking about this project, you might see even from the scoping phase that patient representatives were involved from the very beginning. So I think multidisciplinary teams should include patients and patient representatives. However, I need to again reflect back to Anna, who mentioned that in some cases it might not be needed or even too complicated. But I think for such kind of global project where we are not talking about specific patients, I think we have something to add. And also the co-creation of the method was delivered by the patient and the patient representatives. Once we go to research, because as you might know or might think, this work actually included lots of research work. Once it comes to having a clear picture on undiagnosed patients, you need to map all the available methods how you can diagnose patients. And for that, there was a very sophisticated literature research. Based on that, we managed to identify some of those tests which are needed. And as Anna mentioned, there were 4 rare diseases, which are probably the more prevalent rare diseases among other rare lung diseases. And we thought that it might be practical to pick some of those tests. Based on that, you can see that whether or not these patients are living with those conditions. If they are not, they can go to the undiagnosed patient pathway as it was discussed. But once it is identified that probably that patient were not tested, for instance, right heart catheterization for pulmonary hypertension, because in that specific country, for instance, it's not available or not reimbursed. In such a case, we can refer back that it should be delivered at member state level, because healthcare is a member state responsibility, and we always need to consider subsidiarity. So if there's not a complicated case we are facing, it should be handled locally in member state. But once we have those patients who are having these tests or manage to face all these diagnostic tools, and we still do not know what the patients are living with, they should be escalated and they should be put on this undiagnosed patient pathway. So there was a very long, time-consuming research figuring out what kind of recommendations there are for diagnostic tools. So we have lots of guidelines, as you might know, for each and all disease areas. And based on that, there was a huge list. I cannot recall how many tests there were, but anyways, physicians tried to filter them and come up with a list what kind of test should be at least done in order to be released the patients to this undiagnosed patient pathway. It was quite technical, so patients were not involved at that work, but we were also part of trying to contribute to this. But once it comes to the patient advisory group, we tried to share the red flags, and I think it was quite practical. And once it comes to the last phase, the design, it is obvious that the co-creation was the main part and the most followed engagement approaches. So once you could see those nice slides, some of the patients contributed with the red flags. Also, there was a poster because this initiative was presented in Bologna. So there were a couple of materials which were co-created by patients as well as physicians. Next slide, please. I already mentioned the enablers. So without these main pillars, it is not possible to talk about real teamwork. It is not possible to talk about patient involvement. We have a very fostering atmosphere within ERN LUNG. We have a very strong culture and governance. You can see on the left-hand side that patients are part of the medical steering committee, the strategic working group, many core networks, how we call the disease areas, as well as the functional committees, which are, for instance, quality assurance, guidelines, registries, and so on, and naturally some projects. So this is a guiding principle for this and enable that patients can participate in such kind of work. And naturally, if it is not coming from your coordinator, it might be quite difficult to contribute meaningfully. Leadership style might be also a kind of thing you need to consider when it comes to culture and governance, where you can ask your coordinator, as it happened, for instance, with this project, that you believe that patients should be involved in a different manner, for instance, launching a special work stream when it comes to projects. Patients, we always know that it's quite difficult to work with us because sometimes we disappear due to our condition or personal matters. We are not professionals in such a way, but I think we are a very important part of this collaboration. And for our work, it might be requested that we are receiving some help also from URORDIS as well as from the ERNs. So this is how it happened within this project also. In terms of methodology, there was a consensus decision. So patients discussed all these subjects, and naturally, not always case there was a full 100% agreement, but we try to make some decisions. This is the consensus decision. We received support from URORDIS by organizing these meetings, from ERN LUNG providing this Miro board, which I think very useful tool, and you should foster and help your discussion within your ERNs with the help of this tool. And in terms of organizational arrangements, we also received support from the network coordination team when it came to link to other work streams. Competencies, I already touched this upon. So patients and patient representatives have real world data. I know that this is not a specific term for this working group, but I think it's important to emphasize and underline that patient can contribute from their own experience. And resources were also provided by ERN LUNG and URORDIS, which I already mentioned. So meeting minutes, organizing meetings, which should not be put on the patient representative's shoulder, but we could focus on the real deliverables. Next slide, please. You might already saw this slide, but it's a kind of little bit different or fine-tuned, and we already touched upon many parts of this, but I thought that it might be a great wrap-up of this project. So if you would like to replicate this, we are happy to share this visual. So as it was mentioned, each and all cases we are seeing in the structure lots of patients who are, despite the medication, suffering from the very same or even more serious symptoms. So they might be misdiagnosed patients or undiagnosed patients. So locally within the member states, primary care try to address these difficulties. If it is not possible, they are referring to specialized centers. In some countries, there are so-called national reference networks. As you might know, the ERN LUNG structure actually is copying somehow the French network. But in other countries, for instance, in Germany, now there's a work how they can make national reference networks. So at that phase, the patients at the local level, at the national healthcare system, as you can recall, there were a couple of tests coming up, and if the patients are still somehow got stuck in this structure, they might be referred to panel discussions or second opinions to ERN lung system, where we check this feasibility check, which was described by Anna, these many tests. If they are eligible, they can go to a targeted assessment panel under the ERN lung umbrella as part of a multidisciplinary term where we are inviting, for instance, an EXABO case, it might be, or most ERNs are using the CPMS system, so the clinical patient management system. It might be a useful tool for these undiagnosed patients. You can see that hopefully an appropriate diagnosis will be received. In such a case, the patient will be put on appropriate medication. But it might be the case that the patients are still undiagnosed. So let me refer back to the Jardin project, what we can do with these patients. Hopefully, there will be a register for undiagnosed patients, so we can record these patients and they are not lost in the system. But they are going to be referred back to the national system where they try to receive some medication which might help for their symptoms and so on. So in a nutshell, this is the whole picture of this undiagnosed patient pathway. Next slide, please. So cut it short, this collaboration was quite successful. Thanks to Eurordis, they also honored us as a good practice. We have a patient-centered undiagnosed pathway thanks to our patient representatives. You could see that we have a very nice collaboration with our physician partners, and some of the work stream were patient-driven. Next slide, please. I know that it's always difficult to implement such kind of projects in your own ERNs, but I thought it might be practical to underline some of the lessons learned. One of them is that MDTs, so multidisciplinary teams, should include patients. I think it's a very important message. The second one might be that beyond sharing results, patient representatives can actively contribute, even in the early phases. So you might recall we talked about this within the scoping, patients might be involved. And last but not least, you should be never shy, so your input is well taken. Sometimes it might not fit to the whole project, but it might change some of the thoughts, which might result in some of the conclusions. Next slide, please. It might be one of the most important, probably from my end, because it's always help us how we can implement this. And I think it's kind of messages you might consider when you try to negotiate or discuss with your coordinator that you, within your own ERN, you should need such kind of undiagnosed patient pathway. So you should always consider yourself as an equal partner. I think we talked about this one. We receive lots of support from Eurordis as well as from the network coordination team. So you should not deal with these technical things, but rather delivering those things you are experts in. And the most important message is it's never late to start this discussion, because there are many undiagnosed and misdiagnosed patients in the structure, and hopefully this pathway might help them to have an earlier and appropriate diagnosis. I think that was the last slide. Many thanks for your attention.
Thank you so much, Gergely. Thank you so much also to Anna for this great overview and sharing all this information with us. Before moving to the Q&A, I would like to maybe give the floor to Gulçin Gulmiz. She is involved from the Eurordis side in the Jardin work ongoing on diagnose, so maybe she can provide some further information on what you touched base before, Gergely. So Gulçin, please, the floor is yours if you want to share some updates with the audience.
Yeah, sure. Thank you, Nora, so much. I am really impressed by all the work that has been done. And I also want to say a couple of words on UnDiagnosed that URDIS does within the Jardine joint action that I think is relevant regarding the patient-clinician partnership and maybe go a bit beyond. So in Jardine, as URDIS, we set up a task force in order to develop some recommendations on patient organizations for undiagnosed patients in Europe. And the reason is very simple. We want to shorten the diagnostic odyssey for people living with rare diseases. And we think one of the ways is that to put it integrated into the healthcare system. So from our surveys in URDIS, we know that the average time for diagnosis for people living with rare diseases is 4.7 years. And the patients don't take that long once the first symptoms appear. They only take around like 6 months to go to the doctor. And then we know after like all the evaluation and going from doctor to doctor, once they reach to the center of expertise, they also take short time to get a diagnosis. So what we want to do is shorten the time in between from when the patient reaches out to the healthcare professional until they're referred to an expert center. So we wanted to develop some recommendations for patient organizations for undiagnosed patients, and we did it through our task force, which is the Undiagnosed Multidisciplinary Task Force within Jardine. And it is a multidisciplinary task force that includes patient experts from undiagnosed organizations, from national alliances of rare diseases, also experts from ERN, academics, psychologists, researchers, ethicists, and policymakers. So they're all bringing their expertise. And we also had the representatives from ERN LUNG as well. So we're also aware of best practices and also the work that you have both mentioned. So we created both recommendations directed at countries and also recommendations directed at existing or to be founded patient organizations for people living with rare and undiagnosed diseases. They're on like how the European countries should support the creation of sustainable patient organizations for people living with rare diseases, and for organizations specifically how they should prioritize direct patient support, empowerment, how they should ensure the sustainability, how they should make advantage of the existing networks, how they could build and leverage collaborative networks through the help of other organizations like URDIS, like ERNs, or other existing infrastructures, and also how to advocate for early and accurate diagnosis through the awareness, through training on professionals. So there are 2 pages recommendations, and we are in the consultation process at the moment, and we are working with other tasks within this undiagnosed work package in Jardine to be able to publish some recommendations all together with them, and hopefully will help shorten the diagnostic odyssey. So thank you. I hope it's yeah.
Thank you so much, Gultin, yes, for this update. We really appreciate it. Now, yes, it's time for questions. So if someone from the audience would like to ask something to Gergerli or Anna, please go ahead. Sophie, I see your hand is raised.
Yeah, hi. Thank you for the presentations. I just had a question about the undiagnosed patient registry. I just didn't understand, is it like a centralized registry covering all rare disease, or is it individual registries have also a section for undiagnosed patients, or how does that work once you have this OFA code? Is there still like a note saying, yes, it's undiagnosed, but it is a pulmonary disease or a skin disease? Yeah.
Well, thanks. It's a very difficult question, I think, especially when it comes to registries, when it comes to how the existing systems or structure can be modified. Our plan, or actually our thoughts, are around building a rare respiratory registry under the umbrella of ERN LUNG. So those cases which might be referred to us can be stored in this registry. But I understand that there might be some work streams under the Jardin that some of the registries might be supplemented with such kind of code. I also know that in many countries, they are not following the ORFA code, but they also have the different code. So the coding is also might be problematic, but this question is I think it's the heart of how the undiagnosed patients should be handled and how we can really help these people. So short answer, we are planning to make under the umbrella of ERN LUNG.
Okay, thank you.
Thanks, Gergerli. Ines, please.
Sorry, yeah. I'm used to Teams now, and I couldn't find my thing. So this is a question for Anna and also for Gergerli. I was a bit late, so maybe you have covered it. I was wondering, there's two questions. One, how would have the pathway been different if you would have done it just with the input from clinicians and without the patient representatives? What would have been different? That is my first question. And my second question is, and this comes from some discussions that we are having also on Jardan, where we are developing a generic care pathway. And there is this thing that when and Gergely mentioned it, when people are looking for diagnosis, they still need care. So Gergely was saying, and then they go back to their health system and try to find something that can help them. So I was wondering, so that is a very important question. It's not the undiagnosed pathway per se, but these people need care and they are not, out there just, So I was wondering if you might at some point do a phase 2 project to look into this and how that would look like. Again, a generic pathway for maybe lung conditions. By the way, Thomas is not here, but Thomas is involved in this work on Jardan. Yeah, thank you.
Yes, thank you very much for your questions. The problem with the first one is it's very hard to say how it would have looked if they would have not been there. I think what I quite like about it is that we were always thinking about the patient groups being there and sort of looking out for these patients. So I think this is what's important, that I honestly if I would have a rare lung disease like that, I would have absolutely no idea what I should do within the system. Well, no, let's put it that way. For lung, of course, I would probably know who to call and when to call, but if I would have something else where I don't know the people, so I think this is what was very good, that that the patient representatives always said that, they can do that for the patient. So it's I think they really help to do it in a smoother way. I think this is probably if we would if we doctors would have done it, it would probably be okay. I am there, so if anyone comes to my place, I am going to do this. So I think this is one of them. We are very rarely actively going out and looking for patients. So that's probably one of the big differences. And the second question was. What happens to the patient? And that's always very, very difficult. As I said, I'm working in an interstitial lung disease team, and it's always like that. Okay, the patient was here at the Corani, we diagnosed. What happens now? If they get a drug that has to be done through a specialist center, I mean then it's of course a more difficult thing to do, because then they have to come back to us. But in many ways, I think if the healthcare system works well, it should be a patient preference. Do I want to stay with my own pulmonologist who is able to contact the specialist in case of a problem? Is there a two-way communication between the different levels of the healthcare system? Or does the patient prefer to stay at the specialist center? And because in many instances the patient is already so frustrated with everyone, and this was the first place where someone helped them to basically send them back to square one is sometimes very unfair. But of course, a specialist center cannot treat everyone until the end of time. So I think this is something that has to be very gently and effectively done by the care. And probably this is another point where a patient representative might be able to help, or a study coordinator, or I was meaning to say a study nurse or a nurse coordinator might be happy to help, to navigate, this is my number, just call me back if you feel that once you're referred back to your primary care physician, you feel that it's not going well, So, but yes, I understand your question, and I have absolutely. This is very difficult, but it's very difficult with every disease, I think, So yes, we found it. Not every chronic disease. We diagnose you, we are giving you the treatment, but we cannot treat everyone for the rest of their lives. I don't know. It's difficult. It really comes probably from the treatment itself as well, because if we did find something that is manageable with treatment options, and this can be done in a let's say not a primary care but on a secondary level, then probably they will be happy to go back, because usually these are closer for them at home. But I don't know, Gergely, what's your opinion on this? But I think this really has to be done. The word that I was looking for is tact. So it has to be done really well, so the patient won't feel that they are sort of dumped back into the system, but that they have been the part of the conversation, and they can always get back to this conversation if they feel the need.
But Anna, you were referring to the ones that are lucky because they have received the diagnosis.
Yes, I think those who did not receive the diagnosis probably should. Well, I don't know. As I said, I'm a radiologist. I don't treat patients, but with the way I see that they probably should go to checkups at their pulmonologist local level, and then probably, I don't know, once a year, depending on their disease, they should probably be reevaluated. Maybe they don't even have to go up, maybe sometimes it's enough to review the cases, but I think there should be some sort of because we always find new diseases and new treatments, so that they should not be lost to their system. So I think that could be something to get their symptoms treated on their own level, and probably once a year just go back and have a reevaluation. That's how I would see it. I'm a radiologist. I'm very from the sidelines here. Gergely, what is your opinion from the patient representative part?
Many things, Anna, and also Ines. These were very nice questions. So the first one, I would say that we patients managed to make the project more complicated, because originally it was about having a list of tests which are needed, and following that the patients are going to be referred to the ERN lung structure. But we came up with the patient perspective, having, okay, but when do you think it might be the patient undiagnosed? How you believe that you might be misdiagnosed? So I think that the very first phase of this journey was actually raised by patients and patient representatives. And I think it was a very tricky question, and you really picked up my weakest point of the presentation about what to do with the undiagnosed patients. I think it's still under elaborated from this perspective, because they should not be left alone, that is for sure. But as per the ORFA definition, we do not know what to do with these patients. As Anna mentioned, we try to find some medications, and it should be made on a local level based on the proposal of the real experts. So I think that this is the possible best way, that you are in the hand of the very expert key opinion leaders of the specific field, thanks to ERNs. So they might have some ideas. And as Anna mentioned, probably later on there might be some developments which might help these patients. But it might be the case that based on the numbers, and we know that this is the whole concept under the rare diseases in Europe, that we have bigger population, we see more patients, probably we have better understanding of these specific rare diseases, even ultra rare diseases. So if we have key opinion leaders there, we really hope that we can filter some of the undiagnosed or misdiagnosed patients at local levels. If it is not the case, then these patients, and actually there are some cases for this, they might be referred, for instance, for some clinical trials, because these key opinion leaders are part of many clinical trials, so they might refer these very specific patients for this one, or they might have some ideas how the symptoms, as Anna mentioned, can be made better for the patients. But healthcare is on a member state level, so they need to be referred back. But I really hope
Yeah.
that those proposals will be
Thank you
taken
for
into
the
consideration.
yeah, thanks for that, because you keep so I'm just wondering, because those were very nice, they make me reflect. So I'm wondering, okay, so yes, I understand that the objective of the CPMS or whatever system is to diagnose a patient. Patient is diagnosed, for super good. Patient is not diagnosed. I'm wondering, it's undiagnosed. I'm wondering, Gergely, if it would make a little bit of sense to at least include in the report some considerations around how this patient can be managed back home, or how he or she could manage the symptoms, so that it's not just the cold and diagnosed code that he or she receives, or that they don't receive it themselves, their treating doctor receives it, but that there is something else that I don't know. I mean, it would be nice. This is just I'm just dreaming, and maybe it's not easy, because I understand that the panels are set up to do this, diagnose or not diagnose, not to provide maybe advice on treatment. But for the undiagnosed cases, I'm wondering if there shouldn't be something else for them. But thank you both. That was interesting, and congratulations for the pathway.
Thank you. Yeah, and congratulations from my side as well, for sure. Actually, when I had maybe a couple more questions, but for the sake of time, I will only ask one that I think it may be very straightforward, which is, how do you envision like the final product, let's say, of this pathway? Are you thinking of having also kind of a language version of it? So maybe this is a question most for Gergerly. Have you arrived to that discussion yet?
Many thanks, Nora. So actually, we are quite lucky with lung diseases. We have a very strong European Lung Foundation, and they are helping us to make lay summaries even for clinical guidelines. So I think it might be practical once we have the very final one, that some words, but rather a visual, might be practical to have a good understanding of this. But it might be the case that some lay summary will be also appended to the publication.
Okay. Great. Thank you so
Last
much.
question. Are you going to monitor the adoption at national level, if anyone is using it, or have you discussed that within the ERN?
Actually, as I mentioned, the original project was like about how patients can be referred to the ERN lung. But as mentioned, it's getting bigger and bigger time by time. And it's a very valid point. We talk about this with the new project manager, how, these pathways should look like when it comes to an undiagnosed patient. For instance, a question, which level they should be referred to the primary care, because reimbursement issues might occur, or to the expert center, and so on. So there are many, many very teeny questions or sophisticated approaches needed to really finalize this. And it might happen that it might not work for each and all countries due to differences within the healthcare system. So we might bring up, let's say, a template which might be used, for instance, based on Germany's experience, but it might be the case that we need to fine-tune this and really find out how, for instance, this registry can work, how we can share data from that registry to the local level or back and forth. So there are many small points which should be sorted out in order to have the whole project live and go.
Thank you. So we are arriving to the end of this webinar. I would like to thank once again to Anna and Gergerli for your time preparing for this webinar. Thank you so much for that, and also congratulate you once again for the work. Thank you also for Gulcin for being here today with us and sharing the work for Yardan and UnDiagnosed. And to all of you also for being here. We will be sharing with you the slides and the recording. And please, if you have a couple of minutes, if you can fill in the feedback survey that I pasted in the chat, we would be very grateful. So thank you so much, everyone, and have a nice day.
Thank you, everyone.
Thanks for having us. Thank
Bye.
you.
Thanks,
Bye-bye.
Gergely. Bye-bye.
Bye.